5 and 6, it was like a complete no-no. And even when we started our hematology journey, we were told that we have a patient whom we diagnose as CML, we start him on TKI, we kind of drill it into his head that it's a lifelong therapy. But there are rebels in every field, and for me, he's the poster boy of Francois Xavier Mahon, and it was my proud privilege that in my last when Dr. M.B. Agrawal's meeting, he was one of the invited faculty and had the occasion to meet the great man himself. So Francois Xavier Mahon, actually, why is he rebel is because he always looks at what is not read in the paper. So when everybody was looking at the stim therapy, this is the original based on which imatinib was compared to the combination. So everybody was concentrating on the top arm. He was concentrating on the bottom arm. That only on interferon alone, why some people are maintaining remission. So he realized that when only imatinib, so his paper was that even when people were getting treated only with imatinib, and because of adverse effect, people would stop only interferon. It is not that everyone who stopped interferon therapy landed up with the CML again. So he says if the same was true with interferon, why can't it be true for imatinib or any other TKI? Then there were two other papers. Post-transplant, people who earlier in the pre-TKI era, the standard allogeneic transplant was the standard to go. So there again two papers, one in 2001 and other in 2006, people having undergone an successful allogeneic transplant, 100% chimerism, and being declared cure of immunosuppression, they still had, once the ultra-sensitive BCR-ABL transcript measurements were available, it was found that even these people who had been transplanted years ago and were declared cure had some circulating BCR-ABL. So it means there was a circulating BCR-ABL transcript, but they were absolutely fine. They were not relapsing. So that's how the discontinuation of imatinib in people with CML was conceptualized, and he launched the first ever study known as Top Imatinib trial, that is the STIM trial, and he elegantly proved that between 40 to 50%, so of course I'll just explain what the red and the blue arm are, but overall, if you see between 50% of them, after a period of some time, all that who had to relapse did relapse in the first 6 or 8 months, but then all of them maintained remission even without therapy. The red one were the people who had, in addition to imatinib, also taken interferon previously, whereas the blue ones were those patients who were directly started on first line imatinib. So again, he realized that people who had interferon in the pre-TKI era, and so interferon was doing something that it increased their possibility of achieving a TFR. And the long-term outcomes have almost replicated the same, that anybody who had to relapse did relapse in the first 6 to 8 months, and people who did achieve a TFR in the first year continue to do so. And this was the latest update, that most of the people, so now it's been 180-month follow-up. So even at 180 months, the people who are in remission continue to maintain their remission of all therapy. So essentially, treatment-free remission should be the treatment goal, and it should be balanced against the perils of an indefinite therapy based on the toxicity, the cost, and the patient psyche. Why I am saying patient psyche is, when a patient, we diagnose CML upfront and we try and tell him that here is a disease which you have acquired, in which you have to take a lifelong medicine, his psyche is different. Vis-a-vis, when the same patient you say, it could be a 30-year-old person or 40 or a 50, even the person is 50, you tell him that this is a disease in which we can get rid of all your medicines in the next 10 years or 8 years, his psyche changes, his attitude to the disease changes. Not just the issue of, the lower cost of the therapy and monitoring and so on and so forth. If we look at drugs.com, the adverse drug effects of imatinib are so frequent. I mean, 50% of them do have some GI effects, and our patients learn to live with it. Of course, when they land up with a grade 4, grade 3 cytopenias, we'll end up stopping it. But rarely we would stop imatinib if our patient just complains of some nausea, or that he has to go to the toilet because of increased frequency of stool 3 times a day. We'll just tell our patients to live with these. But the fact is that there are these adverse effects which are affecting his quality of life. It is not just the quality of life which is being affected because of the dermatitis, the GI side effects, the muscle cramps, and the pain with which our patient lives with, the little bit of, insomnia, depression, swollen edema, periorbital edema. There is an issue about a GFR. So this was a Brazilian paper which pointed out that imatinib actually lowered the rate of the GFR in people who have been taking imatinib for more than 10 years at a time. So long-term imatinib was not, or any TKI was not just safe, it did lower the GFR. And to validate it, Dr. Rajan Kapoor and me, we designed a study, and it got, we kind of presented it in ASH as a poster the previous year, that what happens in India. It was 233 people, it's a multicentric HCC cohort, 233 people who had taken more than 10 years of imatinib. And we saw in our cohort also that there was a decline in GFR consecutively over, so much so that it turned out to be around 0.5 to 0.6 ml per year drop in GFR over these 10 years in our patients. So basically, if a person is sitting with a borderline kidney functions over a 10 to 15, so if we keep on giving imatinib or any other TKI, eventually we may, land up harming his kidneys irreversibly. So there have been n number of trials. This is a list of the trials in which people have tried stopping imatinib, starting with the STIM to begin with, and the numbers of patients you can see. Some of the studies have been as small as 15 to 20 patients, but some of them, the Euroski has been the largest. They've recruited 460 patients. 750 patients. The second iteration is 480 patients. So we also had our own little, in 2019 in Pune, FMC, we started a prospective trial in which we registered prospectively patients who could be enrolled on stop imatinib trial. And so far we could had 37 patients who have now been off imatinib for close to 8 years now. And in our, the criteria of entry into the study was that minimum 7 years of duration of imatinib, out of which 2 years should have been in deep molecular, or that time, in 2017 when the protocol was being written, that time it was known as UMRD, that is undetectable MRD. But now it is, we all understand DMR, that is any MR 5 or below. And what has been our result is that yes, our patients also, around 16 out of 37 did suffer a molecular relapse, but the other 21 continue to remain in treatment-free remission. And all these patients who did relapse have all regained, all 16 out of 16 have regained their major molecular response between 2 to 5 months. TKI withdrawal syndrome was seen in a very few. And when we, again I requested Dr. Rajan to do this multivariate analysis for me as to what was, so in our little small series of these 37 patients, we realized that early molecular response was the most important predictor as to who will sustain a TFR versus who wouldn't. So these are some other pioneering TFR studies. If you see CML 428, this was a retrospective study from Tata Memorial, which was published. So ours, of course, for various reasons, we have not been able to publish. It is still something is pending, because this will be a first ever from India, which is a prospective study on TFR, and we now got more than 50 patients on it. So currently, the TFR eligibility criteria is completely based on clinical parameters. We look at the clinical profile of the patient, and based on the clinical profile, we say, green, this is a Timothy Hughes given algorithm, that what was the so-called score, the BCR transcripts at diagnosis, and response, duration. So there are all depth of the molecular, and if you meet all yes, 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 everything is in green, we can consider putting patients on treatment-free remission. We stop the therapy, and then we monitor his BCR ABLs every monthly for the first 3-4 months, then 2 monthly over the next maybe a year, and then quarterly indefinitely, at least for 5 years is what is recommended. And if somebody is in yellow, we may just put him on wait and watch. But if it's a red, any one of them, then definitely these are the patients who should never be told about TFR. So current, as we mentioned, current criteria is all about selecting patients is based on their depth of molecular response and the duration of TKI therapy and the duration of deep molecular response. So this is what I was talking about, the Euroski study. The largest number, they again stratified on based on which patients did successfully have TKI, TFR, and those who didn't, based on blast on peripheral blood at diagnosis, which transcript, whether they harbored only the E14A2 or the E13A2, and of course time to DMR. The three multivariate analysis in which they said this determined whether a patient is fit or not. But then, are there any biomarkers? I mean, these were all clinical markers. Because if my patient asks me, ki, Dr. Saab, what is the probability that I will relapse? Today, I'm just giving him a statistical method that 50 to 60% of them won't relapse. And that is precisely the counseling which we do. That there is a 40 to 50% probability that during the follow-up, you may land up getting a relapse, and in which case we will restart your therapy. But what if the patient says that I want to be 100% sure that I do not relapse? I don't want to venture that I'm already on a drug, I'm happy with it, now I stop my therapy, and 3 months down the line you say, ki, please restart. I don't want to go into that. You tell me upfront that if I'm not going to relapse, then only I wish to stop my therapy. Then yes, there are some biomarkers, but because of the small series, they are not yet in the. So one is the early BCR-ABL kinetics. So this was a paper again by the Australian group at Adelaide is doing the maximum work on TFR. So they looked at the BCR halving time. They were doing BCR-ABLs every week, not every month, every week. So for 12 weeks they did BCR-ABL every week, and they looked at the halving time, and they again stratified the patients. So look at the people in the yellow line right on top. Their probability of TFR was as high as around 80%. That is, if the halving time was less than 14 weeks, 35 days, sorry. If the BCR-ABL halving time was less than 35 days, then the probability of going into TFR was around 80%. Then again, this is again Timothy Hughes' paper. They said that this was the most amazing paper which they had. They just did a NK cell population, and if the NK is activated at the time of stopping imatinib, so NK activating markers, if they are present, they had a 100% probability at going into a TFR after stopping imatinib, vis-a-vis those only 20% in case the NK activating receptors were not present on them. The UK people did another elegant study, what they called it the Destinies trial. So they halved the dose of TKI. So instead of 400 of this thing, they made the dose to half, and at the end of 12 months, they again did their subset analysis both on memory B cells and the NK cells, and only those people in which they met the criteria of whatever they had set up a complex criteria of there only the TKI was stopped completely, and the others were switched back to their full doses of TKI, and again they found more than 80% probability of achieving a sustained TFR. And this again from Timothy Hughes' group was lineage specific detection on residual. So even once we get a DMR, we are understanding that if we are able, but that is possible only if you have an MR 6 or below. So they did studies on the granulocyte subsets and the T cell subsets. And people, if the granulocyte subsets was positive for BCR-ABL, 100% of those patients had a relapse. Whereas if only T cells were positive and the granulocytes were negative, then they had 67% chances of relapse. But if both were negative for BCR-ABL, so lineage specific BCR-ABL, if both the granulocytes and the T cells were negative, the bottom line green, 25%. So at least from 50% we can come down based on these biomarkers. Still, we can't say 0 versus 100, but yes, from a 50-50 we can come down to something like a 80-20. So these are the basic, the bone marrow microenvironment, the metab, the epigenetics, which all decide, and eventually it is the immune milieu, the effector, the balance between the effector and the suppressor cells, which will decide. And we have to tell our patients that even after achieving a TFR, there will be a little bit of a persistent clone, which we do not have to worry about. It is not, we are not trying to eradicate the last bit of leukemic stem cell from our body. We are maintaining a level of BCR-ABL to such a low level that our immune system is able to keep a check on top of that. So I would just like to conclude that TFR should be discussed at diagnosis in all our patients. It changes their perspective, their compliance to therapy and compliance to monitoring, what is more important. And when the time for TFR comes, they'll be more than happy to be, willing to cooperate. Regular initial monitoring of BCR-ABL is extremely vital for us to be able to pick up which patients to take up for TFR vis-a-vis whom not to. And molecular relapse predicting biomarkers, as we've just said, whether it is this immune subset analysis, and when more and more studies come, probably they will come in our decision-making algorithm. Thank you.
One question, sir. Say a person who has been on TFR with 0% BCR-ABL, now you start seeing a little bit BCR-ABL coming, not still meeting a criteria for restart. So how frequently do you observe, and do you change the lab? What is your strategy when it starts coming?
Okay, let me put it this way. First thing is, at the time of stopping imatinib, we tell the patient that these fluctuations, that is the most important for our patients to understand, because they don't understand MR5, MR4 and MR6. So we have to tell them that there is probably a little bit of CML still present in the body, which will keep on fluctuate. What we are trying to do, we have brought it down to such a low level that we will now allow the immune system of the body to take care of this low level of BCR-ABLemia, if I may be allowed to use this term, to be available. And in case it does fluctuate a little bit, we should not worry about it. We will stick to our monitoring schedule. So only if it is a blip, I mean somebody, as you pointed out, somebody is 0.00000 and he comes to me with 0.001. So far it was like MR5, and now he's kind of coming to me with an MR4 viremia. Probably I will check again after a period of 30 days to see, but that restarting criteria has to be a molecular response, because that has been proven n number of times. Once it crosses a threshold of 1 in 1,000, then our immune system cannot alone be able to take care of that amount of the malignant clone, because then it translates to about close to 10 raised to 12 malignant cells. A BCR-ABL of 0.1 and above translates to 10 raised to 12 leukemic cells within the marrow. Then of course we have to rely on a chemical therapy, whether it is a TKI or something else. But anything less than 0.1, probably we can still allow in a person whom we know that has met the qualifying criteria for TFR, because this fluctuation is very common, and all of us should not get worried about 0.01 coming up or a 0.02 coming up in between. That is not something to be worried about, because 0.01 today may again come 0 the next month. Yes, ma'am. Okay, ma'am. So this was again Timothy Hughes' paper. So what they did was, once they met a qualifying standard TFR criteria, It means they were MR 4.5 or below negative. So they have developed in their lab an MR6 level detection. Now in MR6, all their patients were eventually BCR-ABL positive. So negative at MR 4.5 or MR 5 level detection, but a vast majority of them were positive at MR 6. When that is to say, when the ABL copies was elevated to 10 lakhs and above, 1 million and above, that will automatically make it MR 6. So then they did a lineage specific. So they sorted out the cells at the time of TFR. If the granulocytes, only after a cell separation, if the granulocytes showed a BCR-ABL positivity, when they took extracted DNA out of the granulocytes of these people at MR6 level, then all of them relapsed. Whereas if the granulocyte DNA was negative for BCR-ABL, but only the T lymphocytes or the lymphocyte subset had, then 67% relapsed. And if both were negative, then only they achieved 18% sustained TFR. That was what they did.
Maybe in general population, we may be having MR6 to quite an extent.
Yeah, most of, in fact, that's what Timothy you just said, that all the people who are going around with a negative BCR, that my BCR-ABL is 0, when we do an MR6 level, they'll all come to 0.0004 or 0005. Because in our country, I tried speaking to most of the people who do BCR-ABL, even getting an MR5, now MR5 most of our people are getting pretty thing. But even coming to an MR5.5 level is a major challenge. MR5.5 means you have to amplify 6 lakh copies of ABL. Even that is a big challenge for the lab. 10 lakhs of those. Because 1 lakh is MR5.
So I saw your paper that 16 patients relapsed after TFR. So how should we counsel them for next TFR? Should we counsel them for next TFR or should we not?
One is, but this time actually we have to be very objective and we should utilize one of the biomarkers. I think today NK cell repertoire is a very easy to do. And in Sarita ma'am's lab and many of the other labs, they are experts at doing your immune subject marker. But this time we do, and then in case your still your cells are not improving, your memory B cells are not meeting the criteria, your NK cell subset, then we might as well counsel that you do not have a biology which TFR could be affected.
Thank you, sir.
So, thanks, Professor Sanjeevan. That's an excellent talk. I invite the next speaker, Dr. Shukriti Gupta, in optimizing. She's a senior consultant and a transplant specialist at Artemis Gurgaon. She's going to enlighten us on optimizing first-line treatment in newly diagnosed CMLCP.
Very good morning to all of you. So my session is a sponsored session, optimizing the first line therapy in newly diagnosed CML chronic phase. So this would be a case-based approach, and my slides have been provided by the Novartis. The disclaimer. And to start with, most of this has been discussed in the very first lecture by Dr. Harshit, but let's take it on a practical level with a patient's case discussion. It's a fictional case of a young patient, and I think most of us would be able to correlate with our day-to-day patient situations that we are facing in our OPD. So this is a 28-year female, professionally qualified and applied for a job. She has been newly married and is also planning a pregnancy, planning a conception in another 2 to 3 years. So while she underwent a routine workup, it was detected that her WBC count was quite elevated. The female was otherwise asymptomatic and having detected a white cell count of 85,000 with a relatively normal hemoglobin and platelet count. Further workup was done by the hematologist. Examination revealed only a mild splenomegaly, 2 centimeters below costal margin, and a peripheral smear revealed proper myeloid maturation with left shift, and basophilia was also present. So this is a young, healthy female with an elevated WBC count which has been detected incidentally. So we need to make the treatment decisions based on the rest of her life and her day-to-day routine schedule and the upcoming logistics of planning a conception. Further workup had revealed a hypercellular marrow with a less than 5% blast, revealing it to be CML on chronic phase, as the cytogenetics detected was 922 translocation, Philadelphia chromosome positive. Also the fish revealed BCR-ABL1 fusion positive, and the qPCR was 68%. Considering the peripheral blood and bone marrow findings and the rest of the examination, this lands up to be by Sokal or Hansford score. It turns out to be a low risk. And considering the rest of the workup for her comorbidities, she is asymptomatic, and we can see her liver function test, renal function test, and the basic cardiac workup shows no abnormality. So now, coming to the decision making, for this young female who's planning a conception, is professionally qualified and falls into a low risk chronic phase CML, where we need to pay attention to the quality of life. When we plan for any first line TKI, definitely we have so many options. That is the first generation, the second generation, and now we have asciminib that is available for again for the first line therapy. So apart from effectivity, we need to see upon the patient other logistics, that is the age, the comorbidities, associated drug interactions, the patient preferences, and the adherence to therapy, which can lead to earlier achievement of a molecular response, and hence we can consider for a stoppage of therapy, that is a treatment-free trial can be given. So these factors are important to be considered now. So as per the ELN guidelines 2020, in CML, we have certain time points upon which we monitor the BCR, ABL, PCR levels, that is 3 months, 6 months, and 12 months, upon which an early molecular response, that is less than 10%, and another molecular response at 6 months should be less than 1%. Then comes a major molecular response, that is less than 0.1%, and further any time we look upon a deep molecular response which is beyond less than 0.01%. So till now, the TKIs that we have been using, the first generation as well as the second generations, had certain unmet needs, which included in terms of the achievement of major molecular and the deep molecular remission. So at the end of 1 year, we can see that patients with first generation TKI did not achieve molecular remission in up to 66.5%, and those in the second generation could not achieve a major molecular response by to the tune of 55.3% of the patients. And then further assessing these patients at the end of 2 years, we have seen that molecular response to the grade of MR4, that is deep molecular response, was not achieved to the tune of 73.4% of the patient at the end of 2 years, and in 65.7% of the patients, those using the second generation. And the MR 4.5, that is the major molecular response, was not achieved in amongst the first generation in 84.8%, and was not achieved even in up to the tune of 80% even in the second generation. So this happens to be a significant unmet need, because the patient adherence, the patient tolerance really needs to be taken care of, and the treatment-free trial can definitely not be considered. So, though this is a very old study, more than 10 years ago, where it was seen what the non-adherence, how can the non-adherence to the TKI, the intolerance or the overall not feeling well by the patient has affected the achievement of the major molecular response or the complete molecular response. So we can see that when more than 90% of the adherence was taken care of, then in that case, the achievement of major molecular response was significant to the tune of 93.7%. Up to 6, this was an overall 6-year study, and the MR4 was also up to the tune of 76%. However, when the adherence came down to less than 90%, the CMR and even MR4 was significantly lowered, significantly. It was not even up to 5% of the patients. Intolerability definitely have its own effects in meeting the definite treatment goals which we expect. There is a reduced quality of life in these patients. A suboptimal dosing happens later in life. There is non-adherence, missing of treatment dosages, permanent discontinuation can happen, and further, we need to switch classes of therapy frequently. So specific side effects of different classes of TKIs, this was already discussed. For imatinib, we have fatigue and myalgias has been a major cause of discontinuation and interruptions of therapy. And further, even in the elderly, there is evidence of fluid retention. With dasatinib, there is again pleural effusion, fluid retention, and QTC prolongation. Apart from this, even GI toxicity, diarrhea is a significant side effect which we see, because of which dasatinib has been withheld in many of the patients. With nilotinib, again, cardiometabolic side effects, QTC prolongation is a very important side effect. And with bosutinib, again, GI toxicity and hepatotoxicity is something important, hampering the daily usage. So, for our particular patient, who is a young female, professionally qualified, and has to carry out, has to be very active in her day-to-day life, so we need to be assured about early achievement of a deep molecular response, so that a treatment-free trial can be given earlier. The regular tolerance of the individual with the drug has to be very good, so that the doses are not skipped and there is a strict adherence to therapy. And other red flag signs, cardiometabolic side effects has to be taken care of. For pregnancy compatibility, we don't really have any therapy which is very much pregnancy compatible except for the interferons. Early achievement of deep molecular response is a very important criteria in this particular patient, and overall the quality of life needs to be preserved. So what is unique about asciminib is that it targets the myristoyl pocket of the ABL component of the BCR-ABL, and its action is away from the ATP binding site, which is seen in other TKIs. So with this unique mechanism of action, definitely there are lesser side effects and there is lesser cross resistance which is seen. So considering the asciminib in the upfront trial, we have ASC4 first trial, which demonstrated a better molecular response at different time points and even a better tolerability. So this graph shows that at the end of 48 weeks, asciminib has been superior to all the TKIs, and it has been especially more superior to imatinib as a first-line therapy. Whereas with the rest of the TKIs, the major molecular response at the end of 48 weeks was 49% and only 40% in imatinib group. It was to the tune of 69% in the asciminib group. Now at the end of 4 years, that is week 96, again the deep molecular response was definitely much more higher with asciminib. So comparing with all the TKIs, it was to the tune of 49% in asciminib group and only 30.9, and in the rest of the arm, it was 27.5%. And with imatinib, it was comparison when it was done, it was 52.5% in the asciminib group and only 23.5% in the imatinib group. So definitely we see that overall response, the major molecular response, whether MR4 or MR4.5 has shown to be at end of week 96 much better in the asciminib arm as compared to all the TKIs. So even the early molecular response, that is at the end of 3 months in CML chronic phase patients, it is to the tune of 90% in the various trials of asciminib, whether with imatinib, whether with all the other TKIs. So asciminib has standard the response rate up to the tune of 90%, whereas with imatinib it was seen to be nearly 60%. And with other TKIs, it was seen to be nearly 80% in the second generation. So overall comparison with the TKIs, it was 90% in the asciminib group and 70% in the other TKIs group, including imatinib. And finally, the tolerability profile, as we talk about, is definitely better in the asciminib arm. And we see that most of the patients, by the end of 4 years, that is week 96, they do adhere to the therapy with asciminib. And whereas in imatinib and other second generation TKIs, the dropout rates has been significantly increased. That is, in imatinib only 52% adhere to the therapy, and in the second generation only 68.6% adhere to the therapy. And out of which only 5% discontinued because of the adverse effects of asciminib, whereas for imatinib it was to the tune of, and other second generation TKIs, it was to the tune of 13%. So again, treatment related time dependent discontinuation of drugs was also compared in this triad with the nilotinib, and over a period of 3 years we can see in this ASC 4-star trial there was a significant discontinuation of nilotinib because of the tolerance, because of the cardiovascular side effects as compared to asciminib over time. So definitely we have seen that asciminib has a much more safety advantage, whether it is major side effects like cardiovascular, pleural effusion, QTc prolongation, and even GI toxicity, the fluid retention. All these side effects are significantly reduced with asciminib based therapy. So now at the end of this lecture, we can say, to summarize, that with the unmet need with the present TKI based therapy which bind to the ATP competitive sites, with the ASC 4 first trial, we can say that overall effectivity of asciminib is definitely better, and there is a better tolerance, because of which we can make our patients strictly adhere to the therapy more and achieve a treatment free trial earlier. Thank you.
For our next session, which is updates on Zosparta in relapsed refractory FLT3 AML from recent congresses, we will be joined online by Dr. Mark Lewis. Dr. Mark Lewis is a professor of oncology, medicine, and pharmacology in the Division of Hematological Malignancies at Johns Hopkins University School of Medicine. He co-directs the Hematologic Malignancies and Bone Marrow Transplant Program and directs the Adult Leukemia Service at the Johns Hopkins Sydney Kimmel Cancer Center. In addition to his role within the Kimmel Cancer Center, he serves on the faculty for the Johns Hopkins Graduate Training Program in Cellular and Molecular Medicine, which is a PhD program that prepares scientists to conduct lab research at the cellular and molecular level that is designed to have a direct impact on the understanding of human diseases. Dr. Lewis has expertise in AML, CLL, CML, ALL, and MDS. Dr. Lewis, am I audible? Dr. Lewis, we can't hear you. Dr. Lewis, could you unmute, please?
Recording in progress.
So can you say something?
Can you hear me now?
Yes, sir. It is audible.
Dr. Lewis, could you just wait a minute? There's again some connection issue and we're not able to hear you clearly. Just give us a minute. Dr. Lewis could, can. We can hear you now. Oh. Yes, sir, we can see your slides.
all rose very nicely over the ensuing 3 months. And this is an important point. Gilteritinib tends to spare normal hematopoiesis quite nicely. And so the patient quickly became transfusion independent on this monotherapy. So she started in January of 2023 and quickly became transfusion independent with a good performance status. And I followed her with just ordinary blood counts every 1 to 2 months. Now, we know that while the type 2 inhibitors will rapidly get resistant, type 1 inhibitors will also get resistance, but it just takes longer. And so 10 months after starting, she showed up with recurrent fatigue and abnormal blood counts, and sure enough, she had recurrent disease. And we know from the Admiral trial that the resistance mechanism to gilteritinib tends to be from RAS pathway mutations that emerge while on therapy. And so we saw this in the Admiral trial. And in fact, it happens in rather slow motion. You can see here from this single cell data, the slow emergence of an NRAS expressing clone in this particular patient. Again, occurring at about 10 months. So we did next generation sequencing on this patient, and sure enough, there's a KRAS mutation that has emerged. So, FLT3 mutations worsen the prognosis. We know this in both newly diagnosed and the relapsed refractory setting, regardless of the type of induction that you use, 7 and 3 or AZA event. Gilteritinib is very well tolerated, selective, superior to salvage chemotherapy, but you must be patient. The responses can take up to 6 months to occur. The long-term survival is best achieved by bridging the responders to transplant and resuming the drug after transplant. And MRD is emerging as an important clinical parameter to guide management of these patients. And I'll stop there, and I guess we can have a discussion.
Thank you so much. Thank you so much, Dr. Lawrence.
in Hodgkin lymphoma. So what were these strong points of BRICAD? One was that in 64% patients, since most of them have a good response after, by the time we do interim PET, we can finish the therapy in 4 cycles, which is just 3 months. So patients have faster social reintegration, quicker recovery from the malignancy, related fatigue, and minimal disruption to their general life. We saw this safety profile. Treatment-related morbidity was better with BRICAD. Also, patients needed lesser transfusion support with BRICAD. Only 24% patients needed a transfusion, whereas 52% in the escalated BACOP needed transfusion. Similarly, platelet transfusions, only 17% requirement in the BRICAD arm as compared to 34% in the escalated BACOP arm. The neuropathy was there in both the groups, lower in the BRICAD arm. Only few patients had grade 3 peripheral neuropathy, only 1% in the BRICAD arm, and most of this had resolved by the end of 1 to 2 years. There was definitely neutropenia in the BRICAD arm as well as the BACOP arm. It being slightly higher in the BRICAD arm in the first cycle. Subsequent cycles, the neutropenia, febrile neutropenia was quite similar. And the trial does recommend the use of GCSF wherever needed, since there's no issues with the interactions with the chemotherapy. So the other strong point of BRICAD was the reduction in the anthracycline dose. Since only 4 cycles were needed for most patients, the cumulative dose of doxorubicin was 160 mg per meter square as compared to 300 mg per meter square, or at max 240 mg per meter square for patients who needed 6 cycles. So lesser anthracycline, safer for the heart and safer in terms of myelotoxicity in the long run. One of the highlights of BRICAD was the gonadotoxicity reduction. We know that with escalated BACOP, not all patients can recover their fertility. Only 39.2% patients recover their fertility, men recover their fertility after escalated BACOPs, and only 72.5% women recover it. Whereas with BRICAD, 95.3% women recovered their fertility, and 86% men recovered their fertility, and there were quite a few childbirths as well following therapy. There were some older patients also on this trial. Fit patients who were 60 to 75 were also allowed in this trial. There were 85 in total, so quite good numbers. Coming to some real world data. So this is a study from Israel where they've used BRICAD in 79 patients. They have reported an overall response rate of 99% with CMRs at PET2 of 83% and CRs of 95%. So the real world outcomes seem quite promising again, and only 4% patients in their cohort needed a consolidative radiotherapy. Obviously, if they're achieving, 83% are achieving CMR at PET2, there's not going to be much requirement for a radiation for consolidation. Again, obviously, we do not have a head-to-head comparison, but most of us, for advanced stage Hodgkin lymphoma, have 2 main options now. Whether we go for Nivo-AVD versus BRICAD, someone has done a cross-trial comparison, and in this cross-trial comparison, they have concluded that in 18 to 60 years of age, BRICAD significantly improves PFS versus the Nivo-AVD arm. Again, this is not a head-to-head comparison, so we have to take it with a pinch of salt. And among the 61 to 75 years of age, Nivo-AVD was associated with a non-significant trend towards improvement in PFS versus the BRICAD arm. The strong point say, it does come with some amount of requirement for supportive care in terms of transfusions and febrile neutropenia management. Thank you.
Thank you, Dr. Tejaswini, as a benchmark for the treatment of advanced Hodgkin. The old standard regimens which we have been using, or we still will go back to the old regimen for certain clinical scenarios?
Absolutely, ma'am. I think in India, we always have to have a conversation with our patient regarding the finances, because at the end of the day, BRICAD, Nivo-AVD, they're very effective therapies, but also financially, very burdensome on the patient. So first conversation will be if the patient can afford these therapies. And then also because with BRICAD comes the added requirement for transfusion support and supportive care, which is not inexpensive either. So for a financially weaker segment, we would still go back to our ABVD. It's still a very effective therapy in many patients. But yes, for someone who can afford it, we would be looking towards the newer protocols.
I invite questions from the audience. There are no questions. We move on to the next session.
Thank you.
It's my pleasure to invite the next speaker, Brigadier Dr. Ajay Sharma. Dr. Ajay Sharma is the Director, Clinical Hematology and Bone Marrow Transplantation, Paras Hospital, Panchkula. So he will be talking about mantle cell lymphoma in 2026, moving beyond intensive chemotherapy.
Thanks, chairpersons, and I am thankful to Dr. Nitin Sood and his to share few quite effort that every year he organizes this meeting, and I think we need to have more of such meetings in Delhi after our Delhi Hematology Group has not become is not carrying on that actively that we initially intended to be. With that, let me go into some details. It may appear a little monotonous to you, the way these cells look when we make the diagnosis. It's actually it's a rare disease. It's not common, and the name is from the mantle cell that this disease actually gets a lymph node here. This is the here. Sorry, I think not good to use the. So this is the area towards here in the the 10 o'clock position. I'm sorry, the 8 what is this 8 o'clock position mental zone, which is like a crescent. It will be more clearer here if you see, which is the mental zone. The cells actually, the B cells on maturation, if you see, they come and they so they come here and they, thank you. So this is the zone that I was talking, alluding to. These B cells, when they come, they're naive B cells, and they come and settle just next to the germinal center in this zone here, the mental zone that I'm talking about, and they prepare for the further maturation and getting exposed to the antigen-based responses that are going to elicit. So this is the naive mature B cell, which actually, if it has a dysregulated immune regulation, the translocation 1114 that takes place results into they have the overexpressed cyclin D1, and they have the CD5 positivity pan B cell, which the markers are positive, and we have the CD19 2022 positivity, CD10 is negative, and that is the characteristic presentation of the identification of the mantle cell lymphoma. The cyclin D1 and this translocation takes place over here chain, and this chimeric leads to the further dysregulated form maturation of the B cell, and once the cell remains in situ as in situ disease for a long time, it further proliferates either towards the classical mantle cell lymphoma or the pleioformic blastoid form, depending upon whether there is a SOX1 expression or not. If there is no SOX1 expression, it results into non-nodal indolent form, or if there is a SOX expression, it results into the aggressive nodal mantle cell lymphoma with blastoid transformation. The prognostic features which determine whether it is going to be an aggressive or not depends upon the Ki proliferation index, which if more than 30%, and like other lymphomas, is a marker for an aggressive disease. If it is a blastoid variant, the survival is poor. The mutations which may be coexistent, TP53, KMT2D, and MYC mutations, they make it more aggressive. The unmutated IGHV is going to be an aggressive disease. Then there's the MIPI scoring that has been made for this. There are, the simple parameters, age, ECOG, performance status, LDH, and WBC counts. When we combine all these scores, this produces the CMIP index, which makes the CMIP risk stratification based disease. While talking about the treatment landscape, a lot has been happening, because for a long time we just had 2 or 3 options available, either either to give R-CHOP or to hyper-CVAT to these patients with very dismal outcome. So there is some interest of the new trials being done in the various direction. So far these trials are actually, they have all revolved around R-CHOP based, and there you can see, it's a little busy slide, but you can just see on these protocol that when combining high dose RSC, because with IRAC treatment, induction of R-CHOP with IRAC followed by rituximab consolidation, and if the patient is subsequently goes after the transplant on rituximab maintenance. This is the standard of care. This is the so far that is being given for most of the patients, and if patient relapses, we go for the immunotherapy, adding BTKIs starting from the ibrutinib onwards. And for the subsequent relapses, we switch over to the other target therapies, adding these further BTK inhibitors. But despite all this, there's some improvement based on the new studies that we have. More studies and trials came up. The triangle study showed that autologous does not add to any benefit for the transplant, and the rituximab maintenance may be much better than that. Then this EA4151 study showed there was no benefit of transplant as consolidation who were MRD negative. In MRD positive patients, maybe there could be some benefit, but not in the MRD negative. And then this EA4181 trial showed that MRD negativity CR rate, you can't improve it further by the consolidation, and even with the BTKs, there may not be much benefit. And finally, we have this LIMA study, which is a long-term analysis, showed that maintenance rituximab after induction and transplant, if patient had MRD negativity, actually does not prolong the overall survival. So all these protocols actually do not add much to the therapy by giving these chemotherapy-based treatment. So there is no apparent benefit of transplant, no apparent benefit of BTK addition to induction combination immunotherapy, the chemoimmunotherapy for MRD negative patients at least. And we don't have any overall survival to the rituximab maintenance. The small response benefit that we get does not actually justify the use of chemotherapy, which has got such a big toxicity. So if we want to improve upon this, we need to see what areas we can progress. First is, our goal should be to identify the high-risk patients by the stratification, by using the MIPI scoring and other genetic markers, that it is genetic MIPI score. Then employing the MRD-guided therapy, and then optimizing the combined chemotherapy and immunotherapy backbone using targeted agents, and then redefining the role of transplant for the MRD-positive cases only, and then adding to the maintenance therapy. If you can work in all these directions, the outcome can be improved. This one, that genetic MIPI score, where we had added the genomic data, that actually gives better stratification than just doing the simple MIPI score, and that actually has been the focus of attention, because that has given rise to certain target therapies having been used in these patients. Then when we look for the targeted agents combination, the several target therapy combinations have been studied, and because if the untreated standard risk mantle cell lymphoma has a very good response to the chemotherapy, that is a known fact, but the second line therapies are usually very, very ineffective after the failure of the first line therapy. Hence, we need to have a deeper response in the initial therapy. That means that we should choose a therapy where we can have very prolonged deep molecular response by the first line of treatment. And then number of approaches are being studied, but the phase 3 studies and the real world analysis of the specific treatment path will be necessary to establish whether the chemotherapy-free approaches that we are going to discuss are going to be of any use. So we have been, there are these studies which are going on, combining the chemotherapy with acalabrutinib, bendamustine versus acalabrutinib, or combining the acalabrutinib with the one of these agents, ibrutinib with R-CHOP, zanubrutinib with bendamustine, or rituximab alone. And so these are the various combinations that have been tried, and the outcome is considered to be better, especially in those patients who were not transplant eligible. When we choose the chemo-free approaches, this one study, the Windows one study, which combined the BTK inhibitors with the rituximab-like agents, the doublets. This was the first study which investigated the BTK-based reduction therapy followed by consolidative the transplant in these patients who were less than 65 years. The 58 patients received ibrutinib with rituximab for 12 cycles and until they achieved the CR. The patients were then treated with 4 cycles of RHCVAD, alternating with the methotrexate cytarabine without consolidative transplant or maintenance. They achieved high CR of 87%. And then even in the older patients, the best CR of 71 was achieved, and the PFS of at 3 years was 87%. This combination had shown a good result where we did not use any chemotherapy, just the BTK and rituximab combination. With these favorable results, an approach could be used as an escalation strategy in patients with suboptimal response to frontline, at least if not upfront therapy. But this actually paved pathway for the adoption of the non-chemotherapy combinations in mantle cell lymphoma. After the success of doublet regimens, the interest came up for the further improving the outcome, because it has been identified that there is a potential synergy of BTKIs and BCL2 inhibitors, both in the preclinical studies and in the real life setting, in upfront as well as in the relapse setting. Number of studies combined venetoclax, rituximab, and BTKIs. The OASIS study, which combined ibrutinib with venetoclax, AVR study, which combined acalabrutinib with venetoclax, and AVO study, which combined obinutuzumab. All these 3 studies showed that the responses were very good, whether we are talking about the CR rates or we are talking about the overall survival. Even the MRD was much superior in these patients by combining these agents with the venetoclax. And none of these actually studied, actually compared the chemotherapy, the user retrospective data. That is the flaw of these studies, but then outcome was still much better. And this study, combining zanubrutinib, venetoclax, and obinutuzumab in TP53 mutated cohort of 25 newly diagnosed patients, which all high-risk patients with poor outcome. The best ORR responses were 96% and 2-year PFS of 72%, which actually is very encouraging in a population where we knew that the outcomes are poor, and with the chemotherapy, this actually is a very encouraging data. Then we have this study where acalabrutinib was combined with venetoclax and obinutuzumab. The high response rates were seen with MRD across in the majority of these patients. I have not included data, but it was very encouraging at 2 years. So that actually, combining these acalabrutinib and venetoclax with obinutuzumab is another combination which has been shown to give the good response. This study I have chosen specifically because it is the very interesting study done by Jan et al. And this was actually presented in the recent, the last ASH also. The acalabrutinib, rituximab followed by Brexicel, anti-CD19 in a newly diagnosed high-risk patients. It's a frontline study of using acalabrutinib and rituximab combination followed by CAR-T in the newly diagnosed high-risk patients. And the MRD data was obtained, and circulating tumor DNA was assessed, and studies based on the principle that achieving the deepest possible MRD inactivity at the beginning of the treatment is the one which is going to matter to improve the outcome and decrease the resistant disease, and obviously reduce the chances of the relapse. Adding to that is the T-cell leveraging therapies. The efforts are there on way to study the CAR-T cell and bispecific antibody therapies in previously untreated high-risk MCL. Should these strategies prove effective, they could lay the foundation of future investigations for the upfront T-cell based therapies in the broader patients. Again, the need of chemotherapy will be further much superfluous once we use these therapy with great success. The MRD negativity is the basis on which we are working using these therapies, because if we can produce MRD negativity, then the outcome is likely to be better. There are several studies which incorporate MRD guided treatment discontinuation of therapy. So at least in these studies, the MRD based remission and then discontinuing therapy has been possible. And if this gets converted into the real life experience, then the outcome is certainly going to be much better. Then what should be our approach? So if we have a patient who is less than 65, 66, is fit patient, which we define as transplant eligible, does not have TP53 mutation. As on today, we still use R-CHOP or R-DAP. Patient achieves in the upfront therapy CR. There's no high-risk biology, then we can maintain with rituximab or ibrutinib. If patient has got high-risk biology, then we should actually go for the transplant. This actually is a quite a standard therapy, but where we have combined the BTKs and rituximab. But patient has got high-risk mutation TP53, then we take him as for the trial, or we use R-CHOP and then go for the rituximab maintenance with ibrutinib both together. If we can add the cellular therapy in these patients early in the course, the CAR T cell therapy or even T cell engagers, this will at least partially overcome the negative prognostic impact of TP53 alteration in these patients. And there is a trial, Carmen trial, which actually is a randomized controlled trial evaluating the efficacy of the safety of Brixi-cell following abbreviated induction of 3 cycles of ibrutinib plus rituximab. And the results are yet to be available, but the initial results are quite encouraging. Obviously, the CAR T with addition of the BTK inhibitors and rituximab, the results are far superior. More than 65 years of age, if the patient has not been given BTK inhibitor in the first line, then we can actually go in for some sort of combination of chemotherapy and then give rituximab maintenance. But if patient is fit and is high risk, then we should choose bendamustine rituximab and acalabrutinib combination, or we can combine the acalabrutinib and rituximab maintenance. If patient is unfit and is low risk, then just giving rituximab or with BTK inhibitors should be good enough, and put subsequently after 2 years we can put the patient on the rituximab maintenance. In 65 plus age group, the various combinations have been studied. Ibrutinib plus rituximab, the very good results have been obtained, 96% of overall responses and 70% of complete response rates of the 42 years month follow-up, median follow-up. The most patient discontinued ibrutinib due to toxicity, but that's a big problem with the ibrutinib. In SHINE study, actually, the risk of death was seen to be higher with ibrutinib, and that led to withdrawal of ibrutinib in mantle cell lymphoma, because it caused the concern about the ibrutinib-related mortality. With high MRD activity, with excellent 2 years PFS and overall outcomes, even the high-risk patient, and they are acalabrutinib, venetoclax, rituximab, and zanubrutinib, venetoclax, Avenidas combinations. So even in elderly patients, these combinations do offer much good options. So how we can actually prevent the relapse is by the MRD reduction. That it should be the target, by the deepest possible sustained MRD activity. MRD-based de-escalation. We should de-escalate therapy based on the MRD, and the Windows 4 study looks at the usage of BTK inhibitors, rituximab with serial MRD assessment, followed by either withdrawal of the treatment if the MRD continues to be positive, then use of glutamate consolidation in a newly diagnosed patient. I'll just take 1 or 2 slides more. So we have for refractory disease the non-covalent BTK inhibitors. Earlier we were using covalent, but these are non-covalent. We have rituximab available. We have going to have sunitinib also soon to be available. The CAR T 5-year data is available. The Brexocel, the Lisocel, and Zemtocel, all these have shown the efficacy in these patients. The key points of this study, the outcomes have been phenomenal, and that speaks of the success of the CAR T in the mantle cell lymphoma. ZUMA-2 trial is still under follow-up, and the results are still being accrued, and they are very encouraging. The bispecific antibodies, glofitamab also is being used, has been approved actually for the subsequent therapies after the disease relapses. Checkpoint inhibitors are not much of use. Antibody drug conjugate like plituzumab also has been used and may offer an option in a refractory disease. So for relapse disease, we certainly have various combinations as we have discussed. Only thing is that we should use these drugs, those drugs which have not been used in the upfront therapy. If the patient has been used BTK inhibitors, we should try to change those combinations subsequently. And the various combinations that have been used in relapse situations have offered a reasonably good amount of responses even in relapse situation. High-risk disease should actually focus on the identification of these genetic markers and try to use the CAR T cell in these patients much earlier. So to conclude, there has been a paradigm shift in the chemotherapy-based approaches in mantle cell lymphoma. The BTKs are increasingly being integrated into the first-line algorithms. We should use them as first-line therapy. The triangle trial has shown that autologous transplant may not be the best option, especially if the MRD is negative. And ibrutinib-based first-line CHOP-like therapy followed by MR, that is maintenance or rituximab, should form the new standard of care in our patients. The BRA calibrutinib may represent the useful option in older patients. Rituximab plus BTK inhibitor is a good combination in elderly patients with comorbidities. With that, I'll conclude and bring my greetings from the Paras Hospital and the other institution where I have been trained earlier. Thank you very much.
Thank you, Dr. Sharma, for an in-depth and engaging presentation.
Easy to diagnose, difficult to treat.
I agree. I completely agree. So the floor is open for questions.
Fit patient of mantle cell lymphoma with blastoid variant achieved MRD negativity, like PET negativity after R-CHOP, RDAP. Would you consider transplant or R-Akala maintenance?
So in our country, the upfront therapy today for even for blastoid is going to be R-CHOP plus ibrutinib or rituximab. If we at all achieve MRD negative VT, I would still go for the transplant because the MRD is not very well established in our country, standardized. So I would offer, we do offer the autologous transplant in these patients because of the outcome is poor. But if we have the possibility of usage of maybe zanubrutinib and we can have these combinations and then we are sure of the MRD that we have achieved, then I think we can do away with the transplant because CAR T is likely to be available soon for usage of mantle cell lymphoma. Also, if ever it is approved in our country, in that situation, we can do away with the transplant. But till that, I think transplant would remain standard of care in our country. Should remain.
And for patients who are like in the 50s or 60 plus with borderline fitness for transplant, would you like go for
50,
transplant?
60, I would still consider for transplant. Actually, the autologous transplant till 65 should not be denied. Beyond 65 also, I think I am one of the proponents up to 70 years would consider a patient for autologous transplant. So I think autologous transplant should certainly be considered till the time we are able to offer CAR T cell therapies to our patient as a routine.
Anyone else? Thank you, sir. Thank you. Thank you for the presentation. I would now like to call Dr. Vishnu Sharma, Professor and Head, Department of Clinical Hematology, SMS Medical College, Jaipur, for his presentation on frontline follicular lymphoma. Is chemotherapy still necessary?
Thank you, chairpersons and organizers, for having me here. So I will be speaking on frontline follicular lymphoma. Is chemotherapy still necessary? So we all know follicular lymphoma is second most common non-Hodgkin's lymphoma after DLBCL, and accounting for approximately 5% of all hematological neoplasm and around 20% of all non-Hodgkin's lymphomas. Incidence rate is in the range of 2 to 4 per 1 lakh per people per year. And we know that it is a biologically heterogeneous disease in terms of clinical behavior and in terms of treatment outcomes. And it is despite the advancement of so much advancement which has happened in the last 5-10 years, still it is incurable disease. So, based on these criteria, the tumor burden can be estimated. Most commonly used criteria is JELF criteria, which constitutes 7 parameters, including presence of B symptoms, 3 or more lymph node areas, largest lymph node or extranodal involvement of more than 7 centimeters, splenomegaly below umbilical line, pleural or peritoneal effusion, organ compression, or the circulating malignant cells more than 5,000, or cytopenia are defined as ANC less than 1,000 or platelet count less than 1 lakh. Other criteria are British criteria or Swedish criteria, which also includes more or less similar parameters. But most commonly used parameter is JELF criteria. The prognostic indices for follicular lymphoma, and the most commonly used indices is still FLIPI, and other parameters are FLIPI2 or mutation guided parameters like 7M7 FLIPI or 23 gene incorporated criteria, which has also been introduced, and these newer and newer criteria are actually used to individualize the treatment for patients. So coming to the treatment of newly diagnosed stage 1 and 2 classical follicular lymphoma, see still the stage 1 and contiguous stage 2 follicular lymphoma, the treatment involves site radiotherapy with or without anti-CD20 monoclonal antibody. Rarely chemotherapy can be used for patients with stage 1 and stage 2 contiguous disease. For patients with stage 2 and onwards, we can use chemotherapy or chemoimmunotherapy or single dose rituximab followed by the maintenance rituximab. For patients with stage 3 and stage 4 disease, the majority of patients do not require treatment, and treatment is basically guided by the tumor burden, which is decided by the JELF criteria. If there is no indication for treatment, these patients should be put on active surveillance with monitoring every 3 to 6 months for 5 years, then annually as clinically indicated. Imaging can also be done every 6 monthly for first 2 years, followed by annually. Patient who requires treatment based on the JELF criteria can be treated with chemotherapy, chemoimmunotherapy, or novel therapy. So first line treatment options are chemoimmunotherapy, which includes bendamustine rituximab, or with combination with obinutuzumab, or R-CHOP, R-CBP, or rituximab lenalidomide. So it is actually based on the patient's fitness and performance status and other comorbidities. Patients with low tumor burden can be treated with rituximab 4 doses followed by rituximab maintenance. And patients who are unfit for intensive for chemoimmunotherapy can be treated with single agent rituximab weekly for 4 doses. And rituximab maintenance has been established as a maintenance therapy, rituximab, for post chemoimmunotherapy for first 2 years, 8 to 12 weekly. So this PRIMA study has established the role of rituximab maintenance in follicular lymphoma after chemoimmunotherapy. As we all know, the overall survival of follicular lymphoma is excellent with the available chemoimmunotherapy, but these patients tend to relapse over the period of time, and these patients require subsequent line of therapy. When we look at the rituximab maintenance arm, the progression-free survival was much better compared to patients who didn't receive rituximab maintenance. The 5-year progression-free survival was 92.2% in the rituximab arm compared to 70.3% in the control arm. So this emphasizes the efficacy of rituximab maintenance post chemoimmunotherapy. It is more important for patients with intermediate and high risk FLIPI score compared to patients with low risk FLIPI score. So patients with intermediate and high risk benefited more in terms of progression-free survival while received rituximab maintenance. Coming to the rituximab monotherapy versus watchful waiting for advanced stage asymptomatic low tumor burden follicular lymphoma, long-term results from a randomized phase 3 trial. So it was open label randomized phase 3 trial conducted over more than 100 centers in 5 countries. Adult patients more than 18 years of age with asymptomatic low tumor burden, stage 2 to 4, grade 1 to 3A the lymphomas were included with good performance status of 0 to 1, and these patients were randomized into 3 arms. Arm 1 received watchful waiting. In the arm 2, patient received rituximab 375 milligram per meter square for 4 weeks. And arm 3 received rituximab induction 375 milligram per meter square weekly for 4 doses, followed by rituximab maintenance for 2 years, 8 weekly, total 12 doses for the next 2 years. And primary endpoint was time to next lymphoma treatment. And median follow-up was close to 15 years, ranging from 13 years to 15.6 years. And you can see the median time to next anti-lymphoma treatment was 5.6 year in the watch and wait and watch arm compared to 14.8 years in the induction only arm, and it was not reached in the induction plus maintenance arm. And it can be appreciated in the Kaplan-Meier curve also. The patient who were kept on the watchful waiting, the PFS was much, the time to next lymphoma treatment was shorter compared to patient who received rituximab induction followed by rituximab maintenance. Although the overall survival was very much similar, there was no difference in overall survival in all these 3 arms. And there was no difference in the disease, the transformation also. So there was no difference in overall survival as well as the Richter transformation in all these 3 arms. So key conclusion of this study was early rituximab significantly delay the need for subsequent treatment compared with watchful waiting in patients with advanced stage asymptomatic disease who actually didn't require treatment. The greatest benefit was observed in rituximab induction followed by maintenance arm. The result in the longest treatment-free survival, the interval over nearly 15 years of follow-up, and there was no significant overall survival advantage, and there was no difference in the Richter transformation, and the rituximab was well tolerated. So early rituximab is reasonable alternative for those wishing to delay disease progression or defer future therapy. So rituximab can be used in patients who are asymptomatic, low tumor burden to delay the subsequent therapy, but there was no difference in overall survival and disease progression. Next study, lenalidomide plus rituximab for previously untreated newly diagnosed follicular lymphoma, the relevance trial. It was multicentric international randomized open label phase 3 trial where more than 1,000 patients were enrolled, and patients with previously untreated newly diagnosed grade 1 to 3A follicular lymphoma with stage 2 to 4 disease, high tumor burden according to Guelph criteria with good ECOG performance status, and age more than 18 were included. And the exclusion criteria were grade 3B or transformed lymphoma, CNS disease, the peripheral neuropathy, seropositivity, creatinine clearance less than 30, the steroid patient who received steroid for more than 28 days with more than 10 milligram daily dosage, and prior use of lenalidomide, history of malignancy other than follicular lymphoma. These were the patients who were excluded, and newly diagnosed the high tumor burden follicular lymphoma included. And patients were randomized into 2 groups. The group 1 received lenalidomide 20 milligram daily for from day 2 to 22, and rituximab 375 milligram per meter square like on day 1 for in the total 6 cycles. And patient in the second arm, patient received investigator's choice chemoimmunotherapy, R-CHOP, RCVP, or BR. Patients were randomized into 2 groups. And subsequently, rituximab maintenance was started in both the groups at a dose of 375 milligram per meter square every 8 weekly for 2 years, and lenalidomide 10 milligram daily for first year. The primary endpoint was CRR, which includes CR and undetermined CR, and key secondary endpoints include overall survival, event-free survival, duration of treatment, and time to next anti-lymphoma treatment. You can see the 10-year progression-free survival in both the arms were comparable, and there was no difference in rituximab plus chemotherapy versus rituximab plus lenalidomide. So this shows the non-inferiority of Len-Rituxi in terms of 10-year progression-free survival for newly diagnosed follicular lymphoma. Overall survival was also exactly similar in both the groups, and there was no difference in overall survival. And time to next lymphoma treatment was slightly later in patients who received rituximab plus chemotherapy compared to rituximab plus lenalidomide, although the difference was not statistically significant. And according to the baseline characteristic, the PFS was all in both the arms almost similar, with hazard ratio close to 1 in terms of progression-free survival. When it comes to the adverse events during treatment period in the safety population, the majority of the neutropenia and thrombocytopenia were commonly seen in patients who received chemoimmunotherapy as expected, and diarrhea and the skin side effects were more common in the lenalidomide arm. So to summarize this trial, the rituximab lenalidomide provides long-term efficacy comparable to rituximab chemotherapy in previously untreated patients, and at 10 years of follow-up, PFS, overall survival, time to next lymphoma treatment, duration of response were similar in both the groups. 10-year overall survival did more than 80% in both the groups, highlighting an excellent long-term prognosis of modern frontline therapies. Rituximab avoids conventional cytotoxic chemotherapy, and you can give chemotherapy-free first-line treatment for patients who are like requiring chemotherapy or treatment. Toxicity profile differed in R-LEN and chemotherapy. The diarrhea, rashes were more commonly seen in patients who received R-LEN compared to patients who received R-chemo, where the hematological toxicity, infection, neuropathy, and alopecia were more common. Choice between R-LEN and R-chemo should be individualized based on the patient's age, comorbidity, toxicity preference, fertility concerns, and quality of life consideration. And the 10-year analysis confirmed that the R-LEN is an established frontline the standard of care for patients who are newly diagnosed follicular lymphoma, high tumor burden requiring treatment. The next option is obinutuzumab with lenalidomide. So obinutuzumab is another anti-CD20 monoclonal antibody. So obi-len in advanced previously untreated follicular lymphoma in need of systemic therapy, a LISA study. So it was also open label international multicentric phase 2 study in adult patients with newly diagnosed follicular lymphoma with high tumor burden requiring treatment. So more than 100 patients were enrolled, newly diagnosed follicular lymphoma with grade 1 to 3A follicular lymphoma, advanced stage disease, high tumor burden with good performance status, more than 18 years of age. Median age was 60.5 years. Exclusion criteria were active CNS disease, known seropositive patients, patients with any serious comorbid medical conditions barring the treatment, corticosteroid more than 10 milligram per day in previous 28 days, or history of malignancy in the past 5 years. And patients received 6 cycles of 28 days, obinutuzumab at a dose of 1000 milligram on day 8, 15, 22 in the cycle 1, and day 1 of cycle 2 to 6, total 8 doses, and lenalidomide 20 milligram per day on day 1 to day 21 in the cycle 1, subsequently day 2 to day 22 in the cycle 2 to 6. And patients who achieved partial response or better response after 6 cycles received maintenance until disease progression or treatment discontinuation. The obinutuzumab was given in the maintenance phase every 2 weekly, total 6 infusions in the first year, along with lenalidomide at a dose of 10 milligram per day. And in the subsequent year, second year, obinutuzumab was given at a dose of 1000 milligram every 8 weekly, total 6 infusions. CCT was used for response assessment in the after 3 cycles at the end of induction, every 6 months during the first 2 years of maintenance, and thereafter every 6 monthly. PET-CT was also used, but it was optional, and the patients with dual score 2 or less were considered in complete metabolic response, and patients with no PET imaging at the end of induction were not evaluated. The response rate according to the 1999 IWG criteria at the end of induction of treatment includes the overall response rate was 92% in the after induction with obinutuzumab lenalidomide, and after end of induction and maintenance, it was 79%. And the best response was 99%. And the CRR was 47% after induction, and it was 63% after the induction and maintenance. PR was 45% and 17% respectively after induction and maintenance. Response rates as per the 2014 Lugano criteria, the overall metabolic response was 94%, complete metabolic response was 80%, and partial response was 14%. So excellent responses with non-chemotherapy drugs in newly diagnosed follicular lymphoma. Adverse events includes neutropenia 48%, fatigue 51%, constipation 42%, grade 3 or more toxicities include neutropenia in 47%, infection 8%, but these were easily manageable with supportive care and growth factors. So key takeaway of LISA study includes chemotherapy-free first-line treatment is feasible in advanced stage follicular lymphoma. Obilen achieved 92% overall response rate, 80% PET complete response, 82% 3-year progression-free survival, and 94% 3-year overall survival. Main toxicity was neutropenia. So a study established the Obilen is an important first-line non-chemotherapy strategy for patients with advanced stage follicular lymphoma requiring treatment. Another study, phase 3 perspective study, where ibrutinib was added with rituximab in the frontline setting in patients of follicular lymphoma requiring treatment. So patients, total 445 patients were randomized into two groups. The group 1 received ibrutinib plus rituximab, and group 2 received rituximab with placebo. Ibrutinib was given at a dose of 560 milligram once daily until disease progression or unacceptable toxicity, and rituximab was given at a dose of 375 milligram per meter square weekly, then every 8 weekly for 12 cycles for 2 years. You can see the progression-free survival, which was superior with rituximab ibrutinib arm compared to patient who received rituximab plus placebo. The median PFS was 42 months in the the ibrutinib arm compared to 32.8 months in the rituximab only arm. So there was 10-month PFS difference was there in both the groups. Forest plot hazard ratio for PFS was also favoring the rituximab plus ibrutinib arm for all the parameters. The rate of overall response rate was 81% in the ibrutinib plus rituximab arm compared to 68% in the rituximab only arm. The complete response rate was also superior. So takeaway points of perspective study includes addition of ibrutinib to rituximab significantly extend the PFS compared to rituximab alone, and there was no new safety concerns, and however overall survival was same. The another study was SKK 35/14 study, where rituximab was used, the rituximab with or without ibrutinib for untreated advanced stage follicular lymphoma was used. But there was the progression-free survival was slightly superior in the investigational arm compared to rituximab alone, but there was no overall survival difference. So adding ibrutinib to rituximab in this study was marginally improved the CR and PFS, but there was no OS advantage. The bispecifics has also been investigated in follicular lymphoma extensively, especially in the relapsed refractory setting. So these are the bispecifics which has been used for upfront also for follicular lymphoma. This is the mosunetuzumab as a first line for patients with high tumor burden follicular lymphoma of a multi-center phase 2 study where mosunetuzumab was used in escalating in the ramp-up doses to avoid CRS and ICANS, and subsequently for 6 cycles, and the patient also received dexamethasone. So total 43 patients were enrolled. Overall response rate was 96%, CR was 81%, median follow-up at 6 months, and grade 3 or more neutropenia was 10%. So this study also, the subcutaneous mosunetuzumab demonstrated highly promising chemotherapy-free first-line treatment for patients of follicular lymphoma requiring treatment. Combination of mosunetuzumab and zanubrutinib has also been investigated, and results are yet to be published. It was also multi-center the open-label phase 2 study where newly diagnosed follicular lymphoma was recruited, and overall response rate was 85%. Complete metabolic response was 74%, and there was no specific safety concerns in terms of CRS and ICANS. And it was the promising chemotherapy-free frontline regimen, very high CR rates and long-term PFS and OS. So this can be also tried for patients with newly diagnosed follicular lymphoma. Glofitamab and obinutuzumab has also been investigated in the first-line setting in phase 2 trial in untreated follicular lymphoma, and total 35 patients were enrolled, 34 available. Overall response rate was 100%. The CMR 88%, 8-month PFS was 95%, so excellent responses in the chemotherapy-free. There was the CRS was 40%, but grade 3 CRS was 3%, grade 3 or more neutropenia 17%. Another study where odronextamab monotherapy in previously untreated follicular lymphoma is also ongoing phase 3 study in untreated follicular lymphoma. Total 13 patients, no dose-limiting toxicity, CRS 4 patients, and all were grade 1, and no ICANS, no TLS. Overall response rate was 100%. Olympia study investigated the odronextamab with chemotherapy, and it was compared with rituximab with CHOP or CVP, and the results of this study is also yet to come. And preliminary results indicated median age the grade 3, 60 years, mostly stage 3, 4, FLIPI, intermediate high risk, overall response rate 100%, CR of 93%, partial response of 7%. So final key takeaway messages: the chemoimmunotherapy remains the benchmark for first-line treatment of high tumor burden follicular lymphoma with proven long-term efficacy and survival outcomes. Rituximab plus lenalidomide is the only chemotherapy-free regimen supported by mature phase 3 data, demonstrating the comparable long-term PFS and OS to rituximab chemotherapy, and we have 10 years follow-up data. CD20, CD3 bispecific antibodies like mosunetuzumab, glofitamab, epcoritamab, and other have been under investigations and showing exceptionally high response rates with overall response rate of 95 to 100% and CR of 70 to 95% in phase 2 frontline studies. Chemotherapy-free regimens may offer important advantage by avoiding cumulative cytotoxicities, including alopecia, infertility, and other cytopenia and other side effects. And long-term durability, overall survival benefit, and optimal sequencing of bispecific antibody is yet to be established. With this, I end here. Thank you.
Thank you, Dr. Vishnu, for a very insightful presentation. The floor is now open for questions. I invite questions and comments from the audience. Move on to the next presentation. Thank you, Dr. Vishnu. We move on to the next presentation. May I invite Dr. Vipul Seth, Senior Consultant and Unit Head, Hemato-Oncology and Bone Marrow Transplant, RGCI, Delhi, for his presentation on longitudinal data of Varnimcel in BNHL, Indian experience.
Good afternoon, everyone. First, I'd like to thank the organizers for giving me opportunity to present this. This is a sponsored session from Hemonet Therapeutics, so the slides are provided by them. So this is longitudinal data presentation of Varnimcel, for BNHL, not presenting the ALL data, it is only about the lymphoma. Background, I'll just say that so everyone knows that there is a huge disease burden of NHL. So there's lots of incidents, and the prevalence is also good, but the prevalence is a bit low because there are lots of deaths, as you can see, and we need to avoid that, especially after the first line treatment failure. And these are the limitations of current treatment. If you know any relapsed patient of NHL, of course, chemotherapy is not curative. It is just a bridge to something definitive. If you know autologous transplant is very good. It has been tried and tested for time, but there are limitations of autologous transplant for a few cohort of the patients where probably CAR-T would do better. And there are few set of patients where autologous would also suffice. But on the whole, the outcome is very dismal after relapsed lymphoma. And this slide clearly shows that I'm not going into ALL details right now. So NHL, you can clearly see that the outcomes are very dismal once they relapse, maybe after second or third line of treatment. And these are the outcomes that we have got with the CAR-T cell. This is Juliet. This is one of the trials. There are so many trials. And the bar has definitely been raised with the advent of CAR-T cell treatment. These are PET responses of one of the representative patients, as you can see. These are post second or third line, very refractory patients. You can see complete clearing of PET scan after giving CAR-T cells. So this is a typical construct of the CAR-T cell. You have a binding domain, which is SC-FE region, which is the most important part of any CAR. Then you have a transmembrane region, not so important, but of course lots of research is going on in modulating that part too. And then there is a co-stimulatory signal. Because this is chimeric, it does not have a physiological signaling pathway, so you have to put signaling in so that CAR start working. It could be 1 BB or CD28. For Varnim cell, it is 1 BB signaling pathway. This is how CAR-T cell therapy is approved. I'll not go into each and every detail. I'll just say that things have started from 2017 when TISA was the first approved CAR for pediatric BLL, and Axicell was the first one for adult lymphoma. This is more than 3 lines of treatment, and after that what has happened is it has been approved in prior lines of therapy like 2 lines or even after first line failure, and now it is being tested for first line treatment in high risk lymphomas. For leukemia it is similar. It is going through a similar path, and the latest trials are for using it upfront for very high risk leukemias. This is the CAR-T journal. This is a short form of Varnim cell. So this is the journey. The first patient, I'll say the GMP facility was established in Bangalore in 2021. The first patient infusion was done in 2022, and the first dossier for commercialization was submitted in 2023, and they received a regulatory approval in 2024. This was in March, April around, and now there is extension of the current trial. So I'm just presenting the results of this earlier trial, but now there is extension of the trial and the recruitment is ongoing, and the data will mature very soon. As you can, so this is how it has been designed. So CAR-T specialty has been designed in fractionated dose. So you give some fraction of the dose initially to see if there is any CRS, and if there is a lot of CRS, then you can avoid further doses or you can modify the doses. Then there is a second dose, and each dose is a 3-day interval, finally followed by the third dose, which is highest dose. So it is 3 million per kg, the last dose, and the first one is 0.5. The total dose comes to 4.5 or 5 million per kg, which is mostly widely accepted dose for NHL worldwide. This is the phase 2 study design. I mean, the phase 1 was not done because it was directly a product that was already tried and tested in Spain from University Barcelona. So this is the phase 2 design where patients underwent leukapheresis if they had refractory lymphoma, and the CAR preparation was done. In the meantime, people are given bridging therapy or patients are not given bridging therapy depending on the state of the disease. And as soon as the product is ready, you get a lymphodepletion chemotherapy, which helps in expansion of the CAR. It has nothing to do with reducing the burden of the disease. And after that, there is CAR-T cell infusion, and the patients are followed up in usual time points that will be there for any prospective study. The end point mainly was overall response rate, which was 1 month and 3 months, and the best response rate was taken as responses, and then the patients were followed up till 1 year at least with serial PET CT scans and bone marrow in cases of ALL, and then other exploratory endpoints were also seen. This is the safety and efficacy data. As you can see, the overall response rate is 83%, which would be very similar kind of responses that you see in most of the CARs. So CARs response is not a problem. You'll always have responses of 80 to 90%, and you should have at least about 75% because that will finally translate into PFS. So it is fairly similar. Most of them having achieved CR, some percentage also having partial response. As you can see, CRS, most of the patients, at least 75 to 80% of the patients had some degree of CRS, which is also very common. I mean, in CAR, you are going to have some degree of CRS, but what is important is there was not an incidence of very high-grade CRS in the NHL cohort, as well as there was not very high-grade incidence of ICANS. So they were pretty safe, and they were associated with at least low-grade CRS, which would happen in most of the efficient CARs. This is already been published, so this is the data of that trial, and I'm not going to go into ALL, so I'm just going to go into NHL, where you can see the median progression-free survival has been reached at around 1 month, so 50%. It is around 50% at 1 year progression-free survival, which is fairly good. So that is what you would expect worldwide, to have up to 40 to 50% progression-free survival at 1 year. And this is much more important endpoint than an overall response rate initially, where most of the CARs, I mean, even if the patient is refractory, they are going to respond in some way or the other. This is overall survival curve, which is much higher than, of course, progression-free survival, because those that progress do get some kind of salvage therapy, which would mostly be bispecific antibodies in cases of NHL. So this is the quality of life outcome, and I'm not going to detail of this diagram, but I'll just see that there were 5 points which were seen. One is mobility, self-care, and usual activities. Other is discomfort, anxiety, and then depression. So all these points were equally weighed, and as you can see with time, you can see most of the patients achieved a very good quality of health outcome. Maybe initially they will have some problems in the initial 3-4 months, but as you follow them up over 9 months to 1 year, they have very good, excellent quality of life, as long as they have achieved some responses. Of course, if they don't have response and they have progressed, the quality of life will not be so good. That is to do with the lymphoma itself, not to do with the drug per se. You can see when you compare it to other international CARs, and out of which the most, I'll not go into detail of this entire table, but I'll just say that it is comparable to most of the international CARs. It is head-to-head comparable to Spanish CARs, and it's good to compare to Spanish CARs because these have originated there. So it's good to know that we are up to the mark with where Spain is. Most of the CARs will have the CRS, like I said, to the tune of 80%, at least some grade, and that is what has been seen in Varnim-cel. The TRM here was 4%, which is in line with most of the studies that you see, 4 to 5%. There was not any incidence of ICHS, and that is quite significant because rather than CRS or ICANS, the HLH is the main point where you would have mortality, because treating HLH is very difficult unless you diagnose it very early and intervene very early. The survival is also in lines with other CARs. Like I said, anywhere between 40% PFS of 1 year is pretty good for these refractory high-grade NHL patients. This is real-world data. This is more maturing now. It is not part of the trial. Like I said, the trial is being extended. This is real-world data, and 41 centers have been doing real-world immunil CARs. You can see that they are fairly divided between north and south. Categories of the patient, like you see, the majority bulk is DLBCL. Of course, many people have recruited follicular and mantle, and also some people have recruited CNS lymphomas, though, of course, that was an exclusion criteria for the trial. But in any real world, since CARs do penetrate CSF, people do recruit CNS lymphomas, whether be it primary or secondary. And this is real world data which was presented in ASH. I'll say till now only 34 patients, but there are updates of more patients now. The median age was 57. I'll not, so just to there were many patients who had extranodal disease, at least 3 previous lines of therapy, so they were extensively treated, bad cohort of patients. 35% of the patients had bulky disease, and even 10% had CNS involvement. 5% of the patients had received previous autologous transplant, so probably this was 3rd line of treatment, because 2nd line would be autologous transplant. Like I said, these are the responses, which is up to 73% in real world, which somewhat correlates with the trial data. Disease types I've already said, so I'm not going to detail of that. This is again responses. So this is just safety and efficacy data. Still, we are very premature for any long-term outcome, so that will be updated soon. So right now the efficacy is at 74%. This is overall response. 56% is complete response. 18% is partial response. Of course, there were 15% progressive disease, and unfortunately, there was up to 9 to 10% TRM, which is also acceptable for a real-world scenario. These are real world safety outcomes. Like I said, median age was 57. The demography I've already said. The CRS all grade was 40%, which is less as compared to trial, but grade 3 CRS was higher, 7%, and that is to do with recruiting. Probably in real world, the cohort will obviously not be as good as trial. There were 5% high grade ICANS also, but overall grade of ICANS is just 10, which is acceptable. And neutropenia, anemia, and thrombocytopenia is part of any CAR. I mean, most of these are related to the lymphodepletion chemo that you give and the prior bridging chemo that you have given. What is important is long-term neutropenia, and that is not seen very often with these CARs, and most of them are manageable with just filgrastim injections. Again, long-term thrombocytopenia is rare, so people requiring L-thrombopac long time is not very common, but you do have, of course, grade 3 thrombocytopenia and neutropenia at the time of infusion. Hypogammaglobulinemia is 16%. These are clinically relevant hypogammaglobulinemia, where you'll replace IVIG for the benefit of the patient. So this is real world evidence from India, still data to mature. I'll just highlight some data from Spain, because I said this trial was initially done in Spain and then brought to India in University Barcelona. More than 600 patients have been treated now, maximum patients in 2024. Obviously with time you will start recruiting more patients. This is the data in NHL. Like I said, anywhere up to 40% is really great for these very refractory patients. The overall survival will be to the tune of 60%, and you can see these are long-term data. These are really long-term. These are 3-year data, but as you can see for any CAR, the plateau will start coming after 1 year, usually even 9 months. If you achieve CR at 6 months, 9 months, then you're more or less not going to relapse and you will achieve this kind of plateau. So 1 year PFS is a very good surrogate for CAR. This is duration of response. These are for patients who achieved complete response or partial response, and excluding the patients who have progressive disease. So obviously these responses will be better than progression-free survival that you see here. For follicular lymphoma, again, this quote is very different. It is not similar to high-grade lymphoma. Follicular lymphoma, you will expect much better responses than a conventional very high-grade lymphoma. These are the follicular lymphoma patients. Majority of them at stage 3 and 4. Majority also had extranodal diseases, and they had received prior HCT. Again, not going to details of each and every column. I'll just say that the overall response rate is 100%, which you will expect for follicular lymphoma because they're very mild, and progression-free survival is anywhere between 70-75%, so it will be much higher than a high-grade lymphoma. Again, 1 year translating into 3-year progression-free survival. These are progression-free survival curves of follicular lymphoma, and you can see they're much more impressive than a high-grade lymphoma. Again, you can see duration of response and progression-free survival and overall survival are nearly similar because most of the patients will respond. So your duration of, so those progressive diseases are not excluded, and as you could see, there were 100% responses, right? That's why these curves are similar. Mantle cell lymphoma is a very different biology lymphoma. I would just actually say that in Seattle, we used to never use same CARs for a mantle cell lymphoma. Here, more or less, the trend is to use the same CARs that we're using for NHL. I mean, it's a different biology. If you look at the receptors for mantle cell, they are much wider than NHL, so you need to increase the construct width also. But in many places in the world, the same constructs are being used for mantle cell lymphoma. You will not expect similar kind of results in mantle cell like DLBCL. It's mostly to do with using these after 3rd line or 4th line. So you have exhausted ibrutinib, you have exhausted autologous transplant, and then you're giving these CAR T cells. And autologous transplant is pretty much standard upfront for mantle cell lymphoma. So these are again cohort of patients, very refractory, more than many lines of therapy. many of them having extranodal disease, and most of them having been exposed to BTK inhibitor or autologous transplant. Again, ICANS and CRS, I'll say it's more or less similar to the NHL cohort. Low-grade ICANS up to 70-80%, and high-grade ICANS to the tune of 10 to 15%, which would be similar to most of the trials. These are the responses. Again, you can see progression-free survival of 42%, which is fantastic. For mantle cell lymphoma, it is really great because it will always be a bit lower than your conventional NHL, or maybe a bit higher depending on the construct that you are using. Again, overall response rates are to the tune of 85%, which you will expect in most of the CARs. And this is comparable to other CARs like Brexacel and Lyso, and even Axicel. This is summary of all the cohort data from Spain. The responses are to the tune of 80 to 90%. I'm not going to responses. For ALL, you can see 1 year survival is 50%, which is great for ALL, but you should also know that many of the patients, at least 30 to 40% of the patients in Spain, are consolidated with an allograft. So you have to take it with pinch of salt. You have to actually see how many patients were consolidated with allograft. So 50% is really good, but with the help of allograft. And you can see in ALL, obviously the curves go down. So it's not like lymphoma. You don't get that flattening of curve after 1 year. People do relapse, but at 2 years is a very good endpoint for ALL. Usually whatever you get at 2 years PFS will translate to a 5-year outcome, and usually people count them as cured if they do maintain PFS at 2 years, and it's around 32%, which is very acceptable. Around 30 to 40% is very great for 2-year PFS. Again, for lymphoma, you have around 40% PFS at 3 years. Like I said, 1 year would translate into 3 years. For follicular lymphoma, it's much higher, 78%. For mantle cell, very impressive. I mean, 58 is extremely impressive. We had much lower responses in Seattle, at least to the tune of 45%. And this CLL and Richter's, I mean, I'm very surprised when I saw this slide. I'll have to actually see the data, because for us in CLL and Richter's, for Richter's, it would never be more than 20. I mean, it's the worst category patient to treat. CLL would be anywhere between 40%. So to have 60% 4 years is really very impressive. I would like to see which line of treatment they used it for, and even for Richter's, when did they actually use it for. So very impressive data. For grade 3 ICANS and CRS, like I said, between 10 to 15%, you will expect grade 3 CRS for a CAR which expands very nicely, and you will expect at least 5% ICANS also up to tune of grade 3 if those CARs expand very nicely. I would like to end. Thank you very much. I hope I'm 2 minutes before time, so I'm open to questions. Thank you very much.
Thank you, Dr. Vipul, for such a presentation. Just one question. According to you, does tumor burden affects the response rate of Burnham cell?
I'll say the responses for CAR, you will always get response. Even if you take full-blown disease, you're going to get response. What is affected is CRS and ICANS. You will have very high-grade toxicity if you take high-burden disease. And if you take high-burden disease, it will not correlate with progression-free survival. I mean, you will relapse. But I don't think responses, I mean, it will be maybe 5% lesser.
The floor is open for further questions.
Dr. Vipul, we've had an ongoing discussion yesterday as well as a few days ago in a different lecture, wherein there was a difference in opinion on how giving a single large dose versus the step-up dose would handle the tumor biology. What is your opinion on that?
So I'll say most of the studies, when you design any CAR trial, it comes from a preclinical study. In your preclinical study, you'll understand how potent that CAR is. If the CAR is very potent, it's good to split. The split concept also came after we started using, so in Seattle, there was no split protocol because we were the first ones to use, but they realized that there was lots of CRS and ICANS, and also subsequently people started doing it. But I'll say there is no one fixed protocol which is good, because what happens in split dose, the cons is like you might not be able to give third dose, which is maximum dose. So you are giving suboptimal dose because and the ideology is that the CARs have expanded enough, but you never know because, I mean, you see kinetics, but it's not exactly correlating, right? So there are cons of splitting versus fixed dose, but each CAR construct has to design its own protocol. I mean, it all comes from preclinical study, your design of the study, actually.
Thank you.
Just one question. So where do you place this CAR T in CNS lymphoma? And as it is not approved yet for CNS lymphoma, how do you counsel the patients whether we can use CAR T for those patients or not?
So that's pretty simple because worldwide, if you see trials, most of the people do exclude CNS diseases, be it ALL or lymphoma, and most of them do use it in real world. I mean, people have done kinetics in CSF and there is very good penetration of CAS. So biologically, it is very feasible. You have to explain to the patient that this was an exclusion and we don't know the outcomes. These are the outcomes in trial. You expect a bit lesser, but CNS anyways is a bad disease. I mean, what do you do for it? Autologous is not going to cure them.
And continuing with that, CNS relapse in ALL. So if you have a patient who is a young fellow and he is chemo responsive and has CNS relapse, and would you consider CAR T in that situation, or because doesn't have the marrow relapse at all?
So sir, again, thank you for the question. One thing I'd like to highlight, CAR T is not any drug which you get in market. Okay? CAR T is different, CAR Ts have different responses. We used to use it for CNS very nicely because it used to penetrate and we had great responses. But here an option of allotransplant is always there. I would say that if a CAR does not have at least 40% PFS at 1 year, then you have to really consider allo, because allo, even haplo will give you at least 40% outcomes. So it's balance between what efficacy you've got. So both are good options, but of course CAR is an option for CNS relapse.
Thank you, Dr. Vipul.
That was a very good talk. And just a quick question, why is it always capped at 5, both yours and the next CAR? Is there any particular reason why is it a manufacturing?
Which one? Sorry,
the dose of CAR T cells at 5. Why is it? Can't be more CAR T be useful?
So again, this is extrapolated from studies. I'll say Spanish people used it because they did it. So normally you do preclinical study and then you go to very high dose levels in mice and you will see where you get toxicity and then you will balance the dose. And then you have to convert the dose from mice to human. That is how it is designed. I think this was 5 because it was 5 for Spanish court, but I know how they got this dose in Barcelona from the mice studies. Okay, usually your NHL dose will be higher than ALL because you have to penetrate the microenvironment. How did Immunac come to this dose? I don't know whether it was from preclinical studies or it was from previous studies. I don't know.
Sorry, just one more question. There was 52 patients who have been harvested and only 34 was available. Is there any particular reason?
So I mean, this is very correlative to even trial data. Not every patient that is leukophorest is going to get the product. This is a very refractory disease. Most of them do progress. Some of them will even die. Some of them will get infection. So you're not going to give CAR T cells when you have got infection. Sometimes there is manufacturing failure because you don't get enough cells. I mean, these patients are refractory. So there are multiple reasons. You'll have to see what are the reasons. Even I'll have to see what.
Yeah, there was 43 given as well. Those transfused. 43.
That's pretty good. If you can give in 80% of the patients when you look for us, that's pretty good data. If it comes down to 60 or something, then it's not so.
So why were these 9 patients censored? That's what my question.
Censored? I don't know. So I'll have to look into those 9 patients in detail. Okay. But these are the reasons I told you usually that they could not. One of my patient I could not give because he progressed and he himself deferred. So he went for palliative care. So I know at least that.
Okay, thank you.
Any further questions? Thank you, Dr. Vipul. With that, we come to the end of the session, a wonderful session on lymphomas. As we can see that lymphoma management is evolving from highly effective chemotherapy regimens like BREDCAD to chemotherapy-free approaches and then to CAR T cell therapy. We are moving towards a personalized approach. Thank you all the speakers and also the audience for your patient listening. And now we have a quiz after this session.
Thank you.
Yes, there is quiz, but before that, we need to conclude the conference now, and it is my duty to do that. Before that, I extend my sincere gratitude to our distinguished faculty for sharing their expertise and coming here, taking time off their clinical practice. My heartfelt thanks to our industry partners and pharmaceutical sponsors for their valuable support in making this happen. I also wish to acknowledge the dedication
and hard work of our organizing committee who worked very hard for over the past few months to make this happen. So thank you to all the delegates for their active participation and engagement during this conference. We look forward to meeting you all again. But before I close, we do have a quiz with Dr. Bharat being the quiz master. So if I can get all the quiz participants to come forward and hope to see you again soon.
Good afternoon, everyone. Can we have all the participants in the front rows? We have Dr. Harshad, Dr. R. Sarvana, Dr. Abhinav Jain, Dr. Manokna, Dr. Krunal, and Dr. Deepesh and Dr. Mayur, and Dr. Varun also. So just, I think it will take around 30 minutes. So it is only 30 minutes between you and the prize money. And we do have some additional gifts also. We'll like to share them with you. So just coming to the rules, we have 5 rounds in this. And each round has 5 questions in it. There is no negative marking till round 4. But in the round 5, we have 1 marks for the right answer and 0.25 minus for the wrong answer. So are we ready, guys? Should we start? Okay. So first round will be round 1, and it is about identifying the cell given in the picture below. There are 5 cells. You have to just mention the name of the cell that is being shown in the picture. The first cell is this. It is a 70-year-old male presenting with bone pains. Name the cell shown in the picture. What do you call this cell in a case of myeloma? Definitely this is a plasma cell, but it has specific name to it. Second part is 30-year-old male with fever and leukocytosis. Tell the name of the cell shown in the picture. You can see a lot of confused faces in the crowd. Coming to the third cell, a 50-year-old male presenting with skin lesions has this specific nuclear cell which is important for the diagnosis. You can see the nucleus of the cell. It is very typical of a patient who had skin lesions with this. To mention the name of the cell. Fourth question is regarding some important phenomenon that we see if a patient is 20 years old with thrombocytopenia, which is not true. Identify the phenomena that is shown in the picture. The first round is the most difficult round, so don't be discouraged. The further rounds might decide the winner. The last one, this is a typical bone marrow finding which is characterized by marked erythroid hypoplasia. This cell has typical, you can see dog ear finding. Name the cell that is shown in the picture. No pathologist here. Okay. This is end of round 1. We'll go to round 2 now. Now the further rounds are a bit more simpler. You can score if you have not scored in the round 1. Round 2 is all about identifying the drug. I think the oncologist will be better in this. So identify the drug. First one is anti-CD79B. What is this drug called as? Most of the questions we have taken from the 2 days of lectures that we had. So if you attended the lectures, I think you must be able to answer these questions. Second is anti-CD33 drug. Anti-CD47 drug that is used in AML. Fourth is menin inhibitor. Dr. Mark had told about menin inhibitors in KMT2A mutations. Fifth one is anti-BCL2 and BCL-XL inhibitor. It's not just BCL2, it is BCL-XL inhibitor also. I think you must be wanting options for this, but we don't have options in round 2. This is the end of round 2. Now let's go to round 3. It's all about full forms. So first is ISHBT. Hematology people must know this. Second is M-SMART, used for myeloma classification. What is full form of M-SMART? Even if you can write 80% of the full form, we'll give you the marks. Third one is pink E score, used for lymphoma. What is pink/E score? Next one is CHIP. CHIP in hematology. Not AI chip, but chip in hematology. And the last one is ELTS score that we discussed in the morning. Should we move to the round 4? So we don't have audience, I think, so I will skip this question. Yeah, okay. So round 4 is all about clinical trials that we have discussed in past 2 days. And so you have to identify the disease and the drug related to the trial. Just disease and the drug. First is ratify trial. What disease this trial is all about and what is the drug that is being used in this trial. We had discussion in the morning for this. Second is Polarix trial. Name of the disease and the drug related to the trial. I think we have sponsored for this trial outside. Third one is IRIS trial. We had discussion about this in the morning itself. Name the disease and the drug related to the IRIS trial. The letter I stands for the disease, for the drug. Hence, for this echelon trial, name the disease and the drug related to the echelon trial. The last one is Calquence trial. Name the disease and the BTK associated with this trial, Calquence trial. With this, we have finished the round 4. For round 5, we have 1 mark for the right answer and 0.25 minus for the wrong answer. This will be true and false type round 5. So, should we start the round 5? So, an AML diagnosis can be made regardless of the blast percentage, true or false? An AML diagnosis can be made regardless of the blast percentage. This is true or false? Second, regarding CLL, lymphocyte doubling time of less than 3 months or an absolute lymphocyte count increase more than 50% over a 2-month period is an indication to start the treatment for CLL. Is this true or false? Focus on the months and the percentage in this question. So 1 mark for the right answer and minus 0.25 for the wrong answer. Third one is translocations 414 and 1416 in the multiple myeloma are considered low risk cytogenetics. Is it true or false? Question number 4. Nodular lymphocyte predominant Hodgkin lymphoma is characterized by presence of lacunar cells which express CD22. True or false? Coming to the last question of this round. The BFM protocol, that is highly effective intensive chemotherapy used for ALL treatment, the name is acronym for the 3 German cities, Berlin, Frankfurt and Madrid. True or false? Are we done? We had one audience quiz, but we don't have the audience, so we'll just ask you 6 guys. This is in syndrome. This doesn't count in the quiz. We have extra prize for this question. Okay, so this is regarding a syndrome which is characterized mainly affecting men. You know the answer, just okay. Okay, we have 2. Okay, okay. You can. Everybody knows the answer. Okay, we'll give you 0.25 extra marks for each of this. You can give one to the guy sitting in the back. You can just tell me your name and give you the prize. Abhinav. This is worth more than 50,000 that you are getting. I'm telling you. Okay. There's one more question that I skipped in the audience quiz. If anyone knows the answer, just raise your hand. Must have seen the answer, I think. No. So, all know CAR-T. What does truck in immunotherapy stands for? Just expand it. Yeah, please. Just expand the truck. Okay. Anyone else want to try? You're almost there. What does truck stands for in this? You can try. We have extra prizes. Deregulated and uncontrolled. We'll give Harshad the next prize. It is called as T cell redirected for universal cytokine mediated killing, and this is worth more than 50,000. Dr. Harshad. Okay. So with this, we end the quiz, and we'll have the results in 10 minutes. So you can have the lunch, and we'll call you after the lunch for the announcing the prizes. Thank you so much.